Okay, so thank you, Andrea. I appreciate it. Beautiful presentation.
Thank you.
Carlos, c'est toi.
Thank you, JP. Good morning, everyone, and welcome again to our weekly case records of the Mayo Clinic Florida Neurosurgery. Today, Dr. Barsukova and I will be presenting the second case. First of all, we would like to thank the multidisciplinary team involved in the care of this patient, Dr. Chichana and Dr. Almeida for the neurosurgery department, Dr. Olomu for ENT, Dr. Susan Sampson for endocrinology, Dr. Stone for neuroradiology, and Dr. Gentaft with pathology. This case is about a 53-year-old woman who presented to her primary care provider in summer 2021 with complaints of forgetfulness. During that appointment, she also indicated a history of non-specific decreased vision, some headaches, and imbalance. She had experienced a 20-pound weight loss. She would bruise easily. And at that point, her primary care provider recommended to get a brain MRI. Past medical history was relevant for anxiety and hypercholesterolemia. Family history was non-contributory. And physical examination, there were no cranial nerve deficits or focal neurologic deficits. This is the MRI that was gotten at the outside institution. And we can see actually a sizable lesion with heterogeneous components. We can see heterogeneous enhancing as well as a few septations showing two components, basically solid and cystic. It also extends to the suprasellar cisterns, and we can see here also compression of the left optic chiasm. Dr. Murray, I don't know if you would like to further comment on this as well.
Sure, a couple things. You can see if you had a T1, these are both post-con, but on the T1 non-con pre, this tumor had a lot of bizarre signal within it. So you had increased areas of increased T1 signal, areas of decreased T1 signal, the same signal characteristics if you were to show a T2. And if you look at the GRE on one of the priors, it's not hemorrhage, which we see often in adenomas because there's no blooming. And what that means is there's proteinaceous junk in there. And the other one little point I would make, there was a CT as well in June 6th of 2022, and there's a little calcification associated with this lesion. So a couple clues, those two little findings I said, although the patient's age, I believe this is, I don't know, 48, 58, 40s, 50s patient, and you have an intracellular, supracellular mass. I mean, if I say that, that's adenoma, adenoma, adenoma. But the calcification, only about 1 to 2% adenomas calcify, cranios about 90%. And then this bizarre signal, kind of this proteinaceous, these multilocular, that's mainly cystic. A lot of those areas you're seeing there, not the septations, but some of that T1 signal you're seeing there is actually intrinsic T1 signal, if you've compared the pre and post. So this proteinaceous, bizarre proteinaceous fluid in very heterogeneous T1 and T2 signal characteristics, cystic, and in the calcification, makes you think about an adenantinomatous craniopharyngioma. That's kind of what I would, and which is also weird because even though that's the imaging, that's not the classic age group for an adenantinomatous. Now there's, I think WHO just classified, there's papillary and there's adenantinomatous. And papillary is going to be more common in your adults, and that's usually more solid. This looks like, if I were going to see that, you would expect this more in the younger age group. So that's my comments.
Thank you so much, Dr. Murray. This will be very interesting when we discuss the pathology report at the end of the presentation. Here's laboratories that we're going also at the outside institution presented by Dr. Barsukova.
Yes, patient has a normal cortisol level and SATH. Well, he actually has a decreased level of total T4 and insulin growth factor, which basically significant with indication of the probably some sense of hypopituitarism. He has a normal prolactin and cortisol, which doesn't really, it's basically indicative with tumor most likely non-functional.
Perfect. Thank you so much. At that point, the patient was referred to Mayo for an evaluation with neurosurgery and ENT. And in the interval period, she complained of increasing headaches. At that point, the team recommended to proceed with an endoscopic endonasal transphenol approach for a lesion resection. The rationale for the procedure, of course, was to decompress that left side of the optic chiasm and get tissue for diagnosis. The surgery was initially scheduled for December 2021, but the surgery was delayed due to personal decisions. And as we just discussed, differential diagnoses include pituitary adenoma and craniopharyngioma at that moment. JP, I don't know if you would like to comment before going to the video.
So yeah, that's a very interesting case, because when you look at that image, the initial reaction is to feel tempted to say, well, it's going to be like a pituitary adenoma and so on and so forth. But every time we see those different characteristics as well, exemplified by you, Carlos, and by Dr. Murray, we have to think about the unusual things. The first unusual thing that comes to mind is subdiaphragmatic craniopharyngiomas. As Dr. Murray put it, beautifully. It's a bit of a unusual age for this type of patient in this presentation, but not impossible. But the one thing is for sure, well, it needs surgery, so we can define what it is, to compress the optic chiasm and proceed with additional treatment as needed. And number two, we need to plan this approach very well. What do I mean by that? It's like you need to get adequate visualization, adequate exposure, adequate maneuverability. And to do that, in a case like this, you cannot consider that you're going to have your 95% chance of a soft resectable pituitary adenoma, because you may very well get in trouble, have a very limited exposure, you start trying to get your curette inside the tumor and trying to get something out, and you're going to fail. You're not going to remove anything at all in this case. And that's why it's so important to remember at least the line of the 4 blues, which is exposure of the medial walls of the cavernous sinus on both sides, exposure of the superior intercavernous sinus, and exposure of the inferior intercavernous sinus. Because with that, you're going to be able to manipulate from outside to inside of the tumor and try to remove as much as that as possible. So in this case, it was, once again, if anything, mostly subdiaphragmatic. So you didn't need to do a transtuberculum exposure based on the image, but very important to keep in mind that in this case, that full exposure is mandatory. It's not optional, it's mandatory. Otherwise, you're not going to get the resection that you need in this case. So let's take a look at the video, and I think you're going to have, oh, and one detail. It's always one detail in pituitary surgery. Where is the pituitary gland? And in this case, I have to say that looking at the image, I had a hard time trying to find it. I was looking at it in the top. I was thinking we'd have it at the top, and you're going to see that the gland was right in front of us, and we had to create a window to work and remove that tumor. So let's see what it shows.
Perfect. Thank you, Dr. Almeida. Here we have the CT that Dr. Murray was referring to. Here's the sagittal view, where we can actually see those a few hyperdensities that were indicating of calcification within the lesion. And we have here the coronal view showing a little bit of mild left-sided nasal septum deviation with bilateral concha bullosa. Dr. Olom, I don't know if you would like to further comment how you plan these surgeries ahead of time, looking at the CT scan preoperatively.
Yes, so looking at the CT scan, it's obvious that you will need to have those concha bullosas reduced, especially on the right side, as they will impede access of the endoscope and instruments. There's always a question as to whether or not we need to do a septoplasty with a septal deviation. I did not feel like the septal deviation was significant enough to obstruct our access, especially with an appropriately sized posterior septectomy. So we opted not to do a septoplasty. And the other advantage of doing that is if you don't do a septoplasty, you also preserve your, it's easier to preserve your mucosa. So first I inject some lidocaine in the concha bullosa. And here I am reducing the concha bullosa, and the key is to remove the lateral aspect of the concha bullosa and preserve that medial portion of the middle turbinate. And that especially helps with preventing olfactory loss. Now I am performing the rescue flap technique. So I have made an incision just inferior to the sphenoid os and brought it anteriorly on the septum. And that preserves the pedicles for the nasal septal flap. And I do that bilaterally. I'm now using a kerosene to complete my sphenoidotomy. And there you can see the sphenoidotomy has been completed. Now I'm performing a posterior septectomy where we're removing the posterior portion of the septum to provide access. We have a slightly different tip here. The claw tip was just what was pulled. So we're using that to complete the posterior septectomy. We do need access for this. So very good inferior access and superior access to the sella. So there are the intersinus septations, and we're going to need to remove those completely as well to provide full access. Now I'm elevating the mucosa off the sphenoid sinus and the sella. And we're going to complete our access by drilling down the rostrum of the sphenoid sinus. So there's the access completed.
Perfect. Thanks, Olu. And Olu gave us like a beautiful exposure that facility. Can you stop the video, please, Carlos? Well, repetition is the word of the day. So once again, optic canal on the right side, clinoid ICA on the right side, optic canal on the left side, carotid ICA right here on the left side, left optic carotid, lateral optic carotid recess here, optic carotid recess here. So we know this is the limbus and the tuberculum. This is the top of the sella. We don't need any of this today because this is subdiaphragmatic, but we need all of this exposed. And of course, with quite good hemostasis as you see here. So let's continue the video. The same technique, eggshelling the bone, and then we basically just flip the bone out as you see there. And then gonna further expose and remove the bone, trying to preserve the floor a bit, at least a bit of the floor, so you can reconstruct that. And then you see here, you can start to see the blue of the medial wall of the cavernous sinus, so to say. So that's the limit there. And then here we start to see the blue again, so that's very important here. And always the superior intercavernous sinus is this blue line here, and then in the bottom we would have the inferior intercavernous. Once again, opening with a sickle blade and then keeping that plane between the contents of the sella and the dura, so separating that sharply with scissors. We're going to mobilize that dura superiorly, and you see that plane pretty clean. And what we have right in front of us here, this is the pituitary gland. So a very thin tissue of pituitary gland right in front of you. And of course, there is no way to mobilize this, and we didn't think that pituitary transposition would be the way to go. So just created a hole and a space in the inferior part of the gland, which should be well tolerated, at least in most cases. So, and after we did that, we started to see this content. You see like this kind of like glue-like content that say a common or atypical, especially for pituitary adenoma. Start sending tissue to pathology and frozen and permanent. And then we got into the tissue itself. So it had this aspect, well, posterior to the anterior pituitary gland. Well, is that like a complex Rathix cleft cyst? Is that like a craniopharyngioma? Anyways, we're gonna remove it. So mobilizing the pituitary gland up and using, microsurgical dissectors. You see here trying to mobilize the tumor away from the pituitary gland. Very easy to differentiate the lesion from the gland. And then with that, we try to kind of do a central debulking of this. And you see, if we were to try just with curettes, we wouldn't get anything out of there. So we had to go and use sharp dissection and sharp cutting to be able to do some central debulking. After that, you go to the edges, to the borders, to the transition and separation between the tumor capsule and the gland, and you see slowly mobilizing that away. So I like to use this one, which we call the hockey stick, the curette, and then slowly mobilizing that away from the medial wall of the cavernous sinus on the left. And what trying to do here is trying to find a plane. You just need to start and find a plane. So we were blessed to find one on the left side, separating from the medial wall of the cavern from the left, and then go from bottom up. And then same thing, try to separate that away from the dura and the floor of the cella. So moving it up. After we move from left and then from the bottom, we're gonna go to the right side. Why the right side was last? Because I had, I wanted to preserve the tissue on the gland on the right. And then here you see with a round knife and then with a 3 millimeters 45 ring curette, mobilizing the tumor from right to the center and then slowly mobilizing that away, as you see right there. And then I'm gonna go ahead and try to find the plane with the top, which was the most difficult one, of course. And then as you slowly mobilize that, starting to pull it towards you from lateral to medial and from top down. Of course, using the suction as a counter traction. So the suction is a counter traction and the pituitary rongeur would be bringing that towards you. And you see we had some additional secretion or whatever that is from the tumor. And then we were bringing it out. You cannot just pull this because if you just pull, you can bring one of the perforating branches supplying the optic nerve. So you got to do it very gently. So it's always traction and counter traction as you see right there. So suction up, mobilizing the tissue and then the tumor coming down. And then we're starting to bring the part that was extending above the diaphragm because the sink would be subdiaphragmatic, but some components would go through the opening of the diaphragm. And then you see that that's being fully mobilized there. And then what we're going to do is we're going to now inspect the top part. It was interesting that in the top part of the tumor, there was actually calcification, right at the superior aspect, the white tissue that you see, that you saw quickly just there in the top. And then you see us mobilizing that from lateral to medial. We're going to be bringing it down and bringing it down. And you see the white aspect, this calcification right here. And then at some point, we make sure hemostasis is fine as well, that we have no issues. And what we're going to be doing is, while preserving the pituitary gland with a clean field, then I'm going to stop working with the suction. I'm going to work with basically the pituitary and then a ring curette, uses the two instruments to bring it down. So I think you're going to show that in a moment. But basically, we're going to be pulling with the pituitary and using the curette right there to provide counter traction as well. So with those two instruments, I was able to move that from the top down, gently, of course, and get a full total removal of this tumor. And then we're gonna send this to pathology. So Dr. Gentoff will have a nice time having fun with this tissue. And that's it. And the tumor is resected then.
Let me ask Carlos, where are you? Right there. Carlos, why did he open the pituitary at the bottom? I mean, the component was above, right? He worked the hardest at the top, and you heard him, saying, oh my gosh, at the top, the calcification, we had to work hard. I mean, if he opens the pituitary at the top, he can get to the top and take that tumor out. So why did he open the pituitary at the bottom?
Probably it would be because of the connection that we have with the hypothalamus and the basically, well, that connection. So basically, if you reach the top, you can cause a more severe hormonal defect after surgery. So you try to minimize the amount of pituitary that you take to get to the tumor, probably.
I think that your assessment as to the consequences are right. The anatomy and explanation may not be. So I'm going to go to Paola. Where are you? Dr. Mead. She's not available. Let's go to Andrea. Andrea, why did he pick the bottom? Dr. Otamendi.
I'm not sure, sir.
All righty, I'm going to go to Dr. Ruiz. Why did he pick the bottom?
It's probably because when he cut in the bottom, the tumor, the weight of the tumor is gonna make that the gravity push the tumor downward.
Dr. Marenko, why did he pick the bottom to open the pituitary?
To spare as much as pituitary gland as he can when he's resecting the tumor.
I'm sorry, I couldn't hear you.
Is it to spare as much pituitary gland as he can when he's going to resect the tumor to ensure?
Yeah, he's always trying to save the pituitary.
Yeah, but just
but why?
So
All right, let me ask it a different way. How is the vascular supply to the pituitary?
It's to avoid the circular sinus.
Wrong. Go ahead, and JP, why don't you explain to them the anatomy of the gland and why you picked the bottom?
So I think, I mean, to me, there are three reasons, right? As Dr. Quinones was saying, all comes down to anatomy, right? Number one, in terms of the trajectory, I like working for 0 degrees. So to go from top down in that angle allows me at least to have a better direction of visualization. Number two, when we work in the middle of the gland in the top inferior part, I avoid going to the lateral aspects that number one, I wouldn't need it in this case necessarily, but also want to avoid the cortical trophs in the most lateral aspect. And number three, as Dr. Quinones was saying, is related with the connections with the pituitary stalk in the top and superior aspect of this, and the supply that we're going to have with this. In this area, in the subdiaphragmatic, we're going to mostly have the supply via the inferior hypophyseal branches. The superior hypophyseal branches will be above the diaphragm and supplying the stalk at that side. So one of the things is that as you mobilize the tumor, it's not that we're going to transect those branches, but when you pull that down, we could have as well, like one of those branches adhering to the arachnoid in that space, they could be injured. And then we could have not only a pituitary stalk problem in terms of vascularization, but also if you injure the whole branch, you can have even an optic chiasm and optic nerve injury. So very important to think about the vascularization of the gland. And remember that the vascularization of the gland is often shared with vascularization of the optic apparatus in this region. So you need to be mindful of that.
And just think about this, the vascular supply comes like this from the top, like an umbrella to the stalk right there. So if he opens at the top, then you have a high risk of doing vascular injury, and the pituitary stalk injury, and then you kill the entire gland. Here, you compromise, and he said it, is that they tend to tolerate it better, so you go at the bottom. Obviously, what I learned with Dr. Wilson many, many years ago, which we learned from Dr. Rotan, is to do a vertical opening. JP did a cross opening at the bottom, so in essence you do the same. You start with a vertical opening, you open it like a side to side, and then you begin to work, and then you do little slits on the bottom. So you immediately went to the bottom, did a cross, and then did a little window right there, and had preservation of the pituitary from the top. So all the vascular supply, the connections to the hypothalamus are preserved. All right.
Very good. Thank you, Dr. Q. Appreciate the points in it. And we try, and as Dr. Q said, we try our best to preserve the gland, but every time you look at this gland at the end, you see the changing colors, it always gives us pause. And in the end of the day, although anatomically it's preserved, like let's see how the patient will do in terms of hormonal function and preservation. So then we went ahead and did and you saw, once you remove this patty, we're gonna see the diaphragma opening. And that's it, that's the diaphragma right there. You see, so this is all supracellular component. The pituitary stalk is preserved. The gland, it was right in front here, as you can see, and in the top. So basically, the gland is there in the top, and the diaphragm is all open there. So then we had to reconstruct all of that, and Dr. Olomo, helped with that. So we started with some gel foam in the top, and then some biodesign to help to cover that defect, both inlay and non-lay. And then we had a nice reconstruction with a flap by Dr. Norma Olomo.
And what I would say for the pituitary, I would tell Dr. Sampson, be ready for a pituitary storm, because there was a lot of manipulation. It's preserved anatomically, so there's going to be issues. I would be ready. I'd be surprised if this patient has normal pituitary function, but that was the price. I mean, even though it was a beautiful preservation of the stalk and the pituitary, this patient is going to have some pituitary issues immediately after surgery, and potentially lasting for a few weeks, months, and potentially, as JP said, may never recover, but we'll see. Let's see what they found.
I just want to mention here the beautiful flap that Dr. Lomo did. And you see, Norma, if you allow me to comment, but this is the type of flap that you want. It's wide. It covers all the edges of the bone around the opening, and it's loose. It's not under any tension. So that was a beautiful flap that he did as well. But sorry for getting into your part of the surgery, Norma. If you have any comments, please. I don't know if he had to leave or if he's here
No,
with us.
he's still here. My only comment is
No
that
comments. But yeah, it was a good flap. Just you want to make sure you have coverage 5 to 7 millimeters around all the edges so the flap can lay down. And then we just use some TCL to hold down the edges and then tuck the edges in with some gel foam there to keep it secure. And that flap will hold nicely.
Perfect.
and
Thank you.
this is the kind of flap, when you look at the post-operative MRI, that whole area is going to look white with contrast because it takes so much contrast. So you're going to be laying it up in the post-op, in the sagittal image especially. You know, and I don't know if we got a post-op MRI on this one or not, but I wouldn't be surprised if we, beautiful dissection pathology, Dr. Genta.
This is a very interesting case. So on the frozen section, we do two different things. We do a frozen section and we do a touch prep. On the touch prep, we just had anterior pituitary cells, and it almost looked like it could be an adenoma, but on the frozen section, we had on the left-hand side, the cystic stuff, and then a little bit of anterior pituitary that, as you can see on low power here, it's on the right-hand side, it's nested. So that's normal anterior pituitary. So when I called back, I notified that, and I figured the stuff on the left was probably contaminant. You get stuff like that in the nasal cavity sometimes. So more tissue was taken and sent again, because Kai told me, well, what about a craniopharyngioma? That it kind of looks like that to us. And I said, well, I don't have anything for cranio here. And he said, I'll get you more tissue. So if you go to the next slide. This is from the additional tissue. You can see on low power, we have this very cystic looking mass or lesion that has some areas that are solid, like in the middle, that has this sort of whitish, almost cartilaginous appearance on low power. If we go to higher power, we can see that there is a mixture of different tissue types in here. On the right-hand side, you have this sort of mesenchymal, almost chondroid, but not quite, but mesenchymal appearing tissue. In the center, you have actual distinct bone formation. And this isn't the metaplastic bone that you sometimes see in a chronic lesion. This looks like the lesion is actually forming it. And then we have these cysts that are filled with sort of this colloid type substance. And around some of these cysts, you can see with the blue arrow, you have this thickened, almost hyalinization around it. This is very reminiscent of some of the sinonasal hamartomas. Now, the only difference is this doesn't, there are several distinct types of sinonasal hamartoma, and this doesn't quite fit into any of those categories. I did discuss with Kai after this case, and I haven't discussed it with JP, but I discussed it with Kai, and he said, absolutely, this was not coming in from this, from say the sphenoid sinus. He said that it was within the sella, and that it was arising probably from the parts, or from the I'm just trying to, I think he
The
said
pars intermedia.
Yeah, pars intermedia.
Mhm.
And so the interesting thing about that is you can have little rests there. You can even have salivary gland rests that do occasionally form tumors like adenoid cystic carcinoma. It's very rare, but it can happen. What I think this is a hamartomatous lesion. It looks benign. It could, why do I say hamartomatous versus teratomatous? If we didn't have those rests there, it would be considered a teratoma, since it would be tissue that's not from that site. But since you do have those rests there, it does look like that, and it would be completely benign. I do have stains pending to support that. I'm basically staining it for stains that are similar to what you get in sinonasal hamartomas. And I'm also doing some stains that stain for germ cell tumors to exclude that. But like I said, it looks very benign. It's multicystic. It has epithelial components and mesenchymal components and is forming bone. So the bone is where the calcifications are coming from. Very odd case. I tried to look up similar ones in the literature. Unfortunately, you get inundated with hypothalamic hamartoma whenever you type in hamartoma and pituitary. So I'm still going through the literature to see if there's anything described like this.
I think this is a reportable case, Mark, to be honest with you. But let's, to stay on time with everybody, because our case is already in the operating room. Can we go and see what happened endocrinologically?
Yes, absolutely. And this was, as we discussed, across 12 resections with the findings Dr. Q just mentioned a few minutes ago. And these are the post-op labs presented by Dr. Barsukova.
Okay, post-operatively, he did has, like a marginal level of the cortisol, and and also indication of the central hypothyroidism, and that's why decision was made to start basically him on thyroid replacement, as well as we discharge him on hydrocortisone, 10 milligram twice a day. He didn't have any signs of DI. And I think he just recently was discharged with, he gonna have a follow-up labs in a couple days, and we're gonna basically reassess him how she's doing.
There's a couple of other things I'd like to add on to that. So she did have some polyuria, and she was started on acetazolamide. This patient could be at high risk for hyponatremia. Carlos and I have been really going through our data and finding that adenomas don't come back with fluid restriction, but the ones that do are the unusual lesions. And then we have acetazolamide on board, which causes a natriuresis into the urine. So we're really going to have to monitor her, and I'll be calling her today and over the weekend as well to ensure she's adhering to fluid restriction. And also, acetazolamide can cover up a little bit of diabetes insipidus. So it stops the delivery of water to the distal tubules. So Dr. Q's comment that maybe we could have had this incredible DI could have been actually masked by the acetazolamide post-op, and we have to be aware of that.
Amazing cases, and I want to make sure that people understand. So what you saw was an extraordinarily complex case, a life and death type of surgery that happened. Any injury to any of those blood vessels could have caused the death of this patient, literally. Number two, the dissection, the preservation of the anatomy, which then translates to some relevance to function. But the most important thing for me is also the fact that with Dr. Sampson, we've been able to get this patient. This patient went home and post-op the number two. Why? Because Dr. Sampson and Julia and everybody, they keep such a strong track. They basically keep treating the patients and taking care of the patients as an outpatient at home or whatever. A lot of these patients come from all over the world, and you can only do this when you have the level of expertise and dedication. Dr. Sampson, she doesn't tell you guys, but all the patients have her number, and they call her, and she calls them. And on the weekends, when I operate on Friday, she's called them, and on Saturday and Sundays and stuff like that. So it's a tremendous amount of work. So congratulations, Susan, and congratulations, Kai and JP and everybody who participated on this tremendous level of care. Gabriel, you want to comment? You saw the cases, you have done these cases. We're pushing the limits of what we do surgically and endocrinologically.
Yeah, no, excellent case and very, very strange pathology for me, because we don't do surgeries often on those hamartomas tumors. So I personally don't know how it looks. So for me, at the end, looks more like a teratoma or something like that, not hamartoma. Those tumor, very, very firm, and all of these changes. So a very strange pathology, of course, reportable, as you say, and good maneuvers of the surgeons in trying to keep the tumor complete and resection almost in block. Very, very
impressive.
Good surgery skills.
Impressive. That's what I think, JP, is reportable. Ray Journal Neurosurgery. Just put it together with Susan and Kai, and just put it out there and mark, because the pathology is fascinating, but also the physiology. And this is probably a developmental arrest, some sort of remnant of development that got stuck right there.
Yeah, I mean, in terms of pathologists, I agree. It's very interesting. It goes back, I think, to the whole line of development, as you're saying, Dr. Q, of the, the oropharyngeal mucosa with the hypothalamus and so on, all those lines related with cleft cysts and xendogranulomas and craniopharyngiomas. And I mean, I don't know what this is going to end up being, but it's quite fascinating. I fully agree.
In 2016, when I first started here in September, we ended up that year with about 10 or 12 pituitary cases. Last year, thanks to Dr. Sampson and the entire endocrine team, we ended up with over 100 cases, and we're on a schedule to do more and more. And every year we keep growing. And as we grow, we get to see a lot of this pathology and extraordinary multidisciplinary management. So congratulations. Susan, thank you for your leadership, and JP, thank you for your leadership. And I pivot to this right here. Andrea, what do we have on Monday? Go for it.
We will have Dr. Fernandez Hill and Dr. Carlos Perez Vega presenting some of their work that they will be presenting at upcoming international meetings. Please join us on Monday.
Great, excellent. Well, listen, sorry that we kept everybody a little bit extra time, but it was worth the wait and worth the time. And join us on Monday, everybody. And have a great, great weekend. Stay safe, enjoy your time, enjoy your family, and enjoy this beautiful city and the world, because we have so many countries around the world. So thank you.
Gracias.
Gracias. Bye-bye.